We live in a world where we have more lifestyle diseases than lifestyles itself. Today, we have one of the most celebrated experts with us who is in the field of diabetes and endocrinology. Someone who is actively engaged with International Learn Society, someone who has contributed to numerous credible publications in leading scientific journals. Please welcome Dr. Ali. Dr. Ali, having 24 years of experience as an endocrinologist, is there anything alarming that you have been seeing recently, and is there something that people should be really aware of?
Thank you for the question, Dr. Rageena. Certainly. Over time, the cases of obesity and diabetes have been increasing significantly and truly at an alarming level. But the more alarming point is that it's happening at a younger and younger age, and we started to see more kids in their adolescent years coming with obesity, early diabetes, and sometimes type 2 diabetes at that age. Although we know the most common form of diabetes, and thankfully not very common, is type 1 diabetes, the autoimmune one. Now we are seeing type 2 diabetes, the one that is associated with increased weight, with older age, happening at a younger age, which is truly alarming.
Doctor, we all know that diabetes cases has been increased recently a lot. And would you suggest any recommendation for the people to understand how can we prevent it, or what lifestyle modification can help it?
Certainly. If we look at the root cause of type 2 diabetes, there are genetic backgrounds. Not everyone will get diabetes, but certainly if it runs in the family, your chance of getting diabetes in general is higher. And it can reach up to 50%. Also, lifestyle. If you get increase in weight, there is a very intimate relationship between weight and risk of type 2 diabetes, and more so in ladies than men, but the risk is very high in both. So things that we can do to reduce that risk for us is to adopt a healthy lifestyle. If we see that our weight is increasing, certainly we need to be mindful of that. Do that exercise. The 30-minute exercise a day that is recommended by the World Health Organization is truly awesome. It doesn't interfere with daily activity. It could be split into 15 minutes in the morning and 15 minutes in the evening. It could be integrated into the daily activities, but it can make a difference instead of the sedentary lifestyle that the new modernity is bringing about to us all. The second thing is the choice of food. Purified and highly processed foods are not good for health in general, but certainly increase risk of obesity and diabetes. And I would concentrate on two important ones. The first one is purified carbohydrates. Okay. These we don't get from nature. The white sugar, the brown sugar, the jaggery, and what goes into it. This we don't get from nature, and our body does not have any difficulty digesting. It goes straight into the bloodstream. And what would the body do? It would want to prevent diabetes, so it goes into storage as fat, and that results in the insulin resistance and the risk of diabetes. Same for highly processed other foods, like let's say juice. Everyone say juice is healthy. I would argue that is not the case. If we take fruit is healthy. That comes from nature, directly from nature. But if we look at a glass of orange juice, how many oranges we put into it? Right. 3 or 4, but no one can eat 4 oranges. We can drink a glass of orange juice, and maybe 2 if we are thirsty. But that's all of the sugar of 4 or 8 oranges. And that is not healthy. So try to have healthy diet that's closer to nature, less processed, have the activities, and most important of which is get checked regularly, because genetics are there, the risk is there. What we can do is reduce that risk. We may not be able to get rid of it completely, but having a regular checkup, maybe once a year as part of the general health checkup, make sure that you don't have high sugar or high cholesterol. It's a good practice, which is certainly highly recommended.
Thank you, doctor. It's actually very interesting. We often might carry a genetic risk. Maybe our family is having, or my father or mother is carrying a genetic risk, and maybe they're diabetic. What is your suggestion based on it? How can we prevent it? Basically, we know that, you carry a gene, you cannot do anything.
Absolutely. You are absolutely right. Our genetic makeup is set. That's what makes us who we are. Right. We cannot change it. at least within the current technology. But what we could do is we could modify all the modifiable risk factors. There are many other things that we can do. For example, we mentioned weight. If we have excess weight, that increases risk significantly. If we take purified carbohydrates and purified and highly processed foods, that increases our risk. If we smoke, that increases our risk.
Right.
If we exercise, we reduce that risk.
Right.
If we have healthy, balanced diet, we reduce that risk. So we look at all the risk factors that we can manage. We try to manage them as much as possible and have earlier checkups and regular checkups. That's the best approach to avoid and reduce the risk of diabetes coming up.
Doctor, many patients actually ask about insulin resistance. I would like you to tell me what is it actually, and can it lead to diabetes?
Absolutely. Insulin resistance is very topical now, and it's certainly increasing in incidence. The way I would consider it is as follows. We cannot live without sugar in our bloodstream, and we cannot live without insulin in our bloodstream. This is our physiology. This is how we are created. When we eat, glucose goes up, insulin goes up, then sugar goes down, insulin goes down. This is how our bodies behave.
Right.
Now, in insulin resistance, the amount of insulin we need to keep the sugar in place is higher. We need more insulin to keep sugar in place. And the body would want to protect us from diabetes, obviously. So it pushes more insulin into the bloodstream to keep sugar in place. But that insulin is protecting us from diabetes, but at the same time, it's a growth factor, and it's a growth factor for fat. So it will result in an increase in fat tissue in our body. And fat in itself, when it increases, it gets stored in the wrong places, like it goes inside the liver, inside the pancreas, and causes more insulin resistance. So insulin resistance increases, so the body needs to increase more insulin secretion to keep the sugar in place. And over time, the pancreas, which is the gland that produces insulin, becomes weaker and tired. It's not able to keep up with the increasing demand. And that is a stage when we start to get into pre-diabetes, when the sugar can, with certain meals, hit up, go high, have a spike, without the body's ability to keep it in check all the time. That is pre-diabetes. And afterwards, when the pancreas becomes weaker, we get into diabetes, when the pancreas is weak, not able to produce as much insulin, and the sugar goes high. So it's certainly, to answer your question, insulin resistance is precursor to pre-diabetes and diabetes, type 2 diabetes for that matter.
Right, doctor. Thank you. Doctor, what is the current guidelines for diabetes management, and what is the recent medications which is available for the patients?
So it's a very interesting question, and over the years that I've been dealing with diabetes, I've seen evolution of the guideline. Initially, it used to concentrate a lot on how we can keep sugar in target and how can we do it safely without causing hypoglycemia and so on and so forth. And now we call this a glucocentric approach. But the current move is concentrating on the patient as a whole, looking at what is the most important for each patient. So it's more personalized to the patient's care and need. For example, if the patient has cardiovascular disease, if they have had a heart attack or a stroke, the treatment would be different to someone who has heart failure, would be different to someone who has excess weight. It would be different to someone who is just having high sugar and they are otherwise fit and well. So that's the change in the guidelines, and we are really blessed to have amazing new medications that enable us to have that personalized treatment for our patients. It's like an art now, which patient to choose for which patient and which condition. And the way I would go about it is all those treatments are available at our disposal, but we personalize it. So when the patient comes to me, I do the full assessment to them. I look at their risk factors. I look at their blood pressure, their cholesterol, their lifestyle. And we always start with lifestyle because there's nothing that replaces that.
Understood.
Whatever medications we give, if lifestyle is not healthy, the medications will be limited, even if they are the most expensive medications. It's not a matter of good or bad there. The baseline of the building need to be strong for the building to be resilient. And that's what we say. Start with good, healthy lifestyle. And from there, we specialize with the treatment. There are classes of medications now that we use that are amazing. For example, a class called SGLT2 inhibitors. It's a mouthful, but what it does, it dumps extra sugar in the urine. Mm-hmm. So if the patient eats food and they get, instead of having a spike of sugar after food, it gets dumped in the urine. So it's a very clever, nifty way of handling excess sugar. Mm-hmm. It doesn't cause hypoglycemia. It doesn't cause those weird symptoms, and it's also independent of insulin. But the beauty of this medication, it protects the kidney on the long term. And we know kidney problem can happen in patients with diabetes. It can protect the heart, especially from heart failure on the long term. And this is a very high risk. Almost 30% of patients with type 2 diabetes end up with heart failure. And it can, as a bonus, cause some weight loss. So the patients can lose 3 or 4 kilograms of weight, which is always a bonus for patients with type 2 diabetes. Another class of medications that we concentrate on, if the patient has had heart attack or stroke, or if they are at high risk of that, it's called GLP-1 receptor agonists. Okay. Those are medications that are classically given as injections, but now there are options that can be given orally as a tablet. And the way they work is they make the insulin resistance reduced. So they work on the root cause. They reduce insulin resistance, and by doing so, the amount of insulin the body has to produce is less because it's more efficacious. Depending on how we consume food. So if we take more carbohydrates, the body will produce more insulin, but if we consume less, it will be far less insulin. But at the same time, they have protection of the heart. They reduce the atheroma, this blockage of the blood vessels to the patients. They reduce the risk to the brain, the neurodegenerative disorders that can happen to patients in general, especially with type 2 diabetes. They seem to be reduced significantly. And we've seen fascinating evidence in patients who are taking them who happen to get a stroke when compared to patients who are not taking those treatments and they get a stroke. Those who are taking those injections tend to have better recovery, less complications. They are more likely to go back to their normal self because of this neuroprotective properties of those medications. If someone has excess weight, they have obesity, their body mass index, which is how much weight for their height is high, then we concentrate on GLP-1 receptor agonist class as well, because it has an appetite suppression benefit. It enhances energy expenditure with exercise, in general with the patients. And also it reduces insulin resistance, which is a big contributor to excess weight. So those are the general kind of new medications that are employed in the treatment for our patients with type 2 diabetes. But at the end of the day, whatever the treatment we choose, it may have side effects, and it's very important to have a candid and deep discussion with your doctor when about the suitability of those medications. Some of them may cause nausea, some of them may cause diarrhea or constipation, change in bowel habits. And if you have that discussion with the patient, if you know what to expect, you'll be guided on things that you can do in your day-to-day life to how to mitigate these risk factors and reduce them in general.
Perfect. Doctor, having a lot of diabetic patients, what is your advice to them? How often they should have a checkup, and what are the things they should make sure they do?
So checkups at home, certainly they need to check their weight regularly, and if it is going high, then alarm clock should be there and they need to visit their doctors. And reflect on their lifestyle. They need to check their blood pressure at home, make sure that it is within normal range, less than 130 over 80 millimeter mercury. If higher than that, visit your doctor. And check your blood sugar. If you can check it with your finger prick, that's great. But if you can get a sensor, the continuous glucose monitoring sensor, that will add a lot of value from an insight about the effect of the medications on your health and your sugar, and about your the activities, effect on your sugar, and your body's response to different foods.
And doctor, how often should our patients see a doctor for any blood test or review?
So we recommend, in general, once a year an annual review for patients. And this annual review will include a general blood checkup, looking at their kidney function, their liver function, their cholesterol. We look also at the full blood count in case there is anemia. We look at the thyroid in case there is excess weight in the patient or if there are symptoms suggestive to that. And also we look at the sugar control, HbA1c and fasting sugar as needed. Also, we take the opportunity to do a retinal checkup for the patient. This is recommended by all guidelines at least once a year. And we look at the peripheral nervous system. For example, we look at the blood vessels and the nerves of the feet so that we avoid diabetic foot problems arising. In addition to that, we do the systemic checkup. We look at the gastrointestinal symptoms, the gut and the stomach. We look at the genitourinary system, and also we look at the mental health of the patient. And depending on the condition, if we institute any change in treatment, we may need to do another repeat checkup in 3 months' time to make sure that the treatment that we've modified is still suitable for the patient's need, the patient's at target, not getting side effects, and they are well with their treatment.
Perfect. Doctor, many patients are really hesitant to start insulin. What's your opinion about it?
I understand the patient's hesitancy regarding insulin, and maybe this is legacy from the past. In the past we didn't have much those advanced insulins that we have now. Patients used to have worry about hypoglycemia and weight gain, but the new insulins are absolutely amazing, and they have transformed the way we handle diabetes. In fact, we've just celebrated over 100 years of insulin discovery in 1922 when insulin became available to humans. And since then, amazing discoveries have happened. And more so, soon we will have the once weekly insulin. We will have an insulin that you inject once a week. That's truly awesome. The way I would say, insulin is the safest treatment. It's the safest treatment we give in pregnancy. So you can imagine how safe it is, to have insulin therapy if that is the need. But this is a decision, you have to take with your doctor. If your health need is insulin, then don't hesitate. It's safe, it's effective, and it is a lifesaver. But nowadays, and I have to admit, we are using less and less insulin in patients with type 2 diabetes. Now, type 1 diabetes is different. They rely completely on insulin. But in type 2 diabetes, the revolution of therapy that I've mentioned have enabled us to avoid insulin therapy in many patients. But whenever we need it, there is no question about it. It's an amazing and safe treatment to have.
Thank you. Doctor, is there any exciting new treatment which is coming for diabetes management?
So yes, the future is very bright, and what is in the pipeline is huge and absolutely amazing. Something that is coming soon, which is once weekly insulin. We all know insulin that is given a few times a day. Now we are going to have once weekly insulin for patients with type 2 diabetes and type 1 diabetes. But also we are going to have an expansion of the class of treatment that is we use now for treating diabetes and weight management, the GLP-1. Now this class is called nutrient-stimulated hormones or polypeptides. And the way we are going to have it is medications that can result in weight loss more than or equivalent to a bariatric surgery, a treatment that can result in an A1C reduction of in excess of 2% weight. We're going to have options of those treatments as tablets, which will save patients having to inject themselves once a week. So what is coming in the future is absolutely amazing. Some of that is already there. We have, some of those injections coming in tablet form, but more on that coming. And we will also be getting injections that will be giving maybe once a month instead of once a week.
That's amazing.
Truly awesome treatment.
Yeah. Doctor, we know there is a lot of injectable weight management medications. What's your suggestion to patients who are using it?
These are revolutionary treatments, absolutely revolutionary. And if I take one step back in the history, we used to have only lifestyle advice, eat less, do exercise, and if that doesn't work, you go for surgery. Now we have amazing solutions that enable patients to lose weight safely. But I stress on this point, safely, when it is done with the consultation of a doctor, when the doctor is supporting you, when the doctor is shadowing you through your weight loss journey. Right. These are strong medications, and if not taken properly and with the right support, you may injure yourself. You may end up with nutritional deficits. You may end up with dehydration. You may end up with side effects that are not favorable. So my advice is, do them safely with the support and shadowing of your doctor. The doctor will do assessment for you, ensure that your nutrient needs are met. Right. You are not becoming dehydrated or having salt depletion or vitamin depletion. Also, the fine-tuning of your treatment can only be done by the support of the doctor. You will not be able to do it safely yourself and reach your target and have a sustainable target.
Right. Doctor, can you list me a few long-term risks of diabetes?
So we know diabetes is a chronic disease, and because it's a chronic disease, it can result in complications over the long term. And those complications, the good news is they can be reduced if we have good diabetes control from the word go. But those complications, unfortunately, still arise in some patients, and some of those are related to the blood vessels. So we can get, retinopathy, when the retina becomes diseased and maybe there is bleeding in it that could potentially result in vision loss. Some patients can get kidney problems because of the small blood vessels inside the kidney become diseased and the kidney stops being able to filter out those toxins. Patients can get neuropathy, what we call it, when the nerves become diseased and they start to send wrong signals, like the patients lose their sense of touch, or they start to get feeling of burning sensation, or like pressure or pins and needles in their feet. And if the nerves that control blood pressure are affected, patients can get a drop in blood pressure at times which is not expected. It can result in problems of the heart, both of the blood vessels of the heart leading to heart attacks, or the electricity of the heart causing arrhythmias, or like irregular heart rhythms in the heart. It can affect also the gut, it can affect the brain, it can result in early dementia, it can result in erectile dysfunction or problems of the gut as well. So all those complications could potentially happen in patients with diabetes, but they can be reduced significantly with good control, with regular consultation with your doctors and support of your doctor to get you on the right path.
Thank you, doctor. Can you list me a few weird symptoms you, being an endocrinologist, would say as never ignore?
Yes, certainly. The way I would frame it is any change to your normal self. Okay. And for example, a change in your sense of temperature, if you feel more than hot than usual or more than cold than usual, if you get a change to your weight that is not expected because there's no change in your lifestyle, if you get delayed wound healing, if you get a delay in your, for the ladies, if there is a delay or irregularity in the period, if there is irregularity of the heart rate, if there is a change to your kind of mood, if you feel more anxious than usual or feel low more than usual, if you get a change to your sleep, this is an important point and should not be underestimated. And also if there is a reduction to libido, both in males and females, that can be a sign of an illness that can be investigated and be corrected.
Thank you, doctor.